Okay, we're ready to go. Okay. All right. Good afternoon, everybody. Again, I wanted to thank everybody for the opportunity to talk with you today about the ongoing coronavirus pandemic. My name is Dr. Alex Garza. I'm here today as a representative of the St. Louis Metropolitan Pandemic Task Force, which includes BJC, Mercy, SSM Health, and St. Luke's. And this is really an unprecedented collaboration amongst the healthcare systems. We're going to do these briefings regularly to really update the people on what's going on with coronavirus, because we know how important it is to get the facts out about what's going on in our community. Now, let me say a couple words about our format. Today we have a couple of reporters here in the gymnasium, and we also have some that are watching online. So we'll take some questions from both here in the room as well as reporters asking questions virtually. And if we miss any of those questions, we'll make sure we circle back around with you to get the answers. We're also going to be looking at doing virtual formats going forward to make this a little bit more efficient, and also sort of practice what we preach about social distancing as well. So let me move on now. So as we mentioned yesterday, we have a very complex problem, but can really be boiled down into a very simple strategy, which is to stop the spread, which then in turn saves lives. I'll talk a little bit in a moment here about the data that we're starting to compile to give you a snapshot of what's going on in the community. But we have every reason to believe that the surge is still coming. And so it is extremely important that we all follow the strategy, which is to stop the spread. And that is by continuing the social isolation, the social distancing, washing hands, keeping surfaces clean, all of those things that we've been talking about. So let me give you a little bit of an update on the data now. And so again, this was compiled from our partners within the task force. And to be clear, we're still refining the process for data acquisition as well. But as of today, we have around 468 patients that are currently hospitalized that are either tested positive for COVID or are a patient under investigation, which means we're waiting for the test to come back from the laboratory. Now, of those patients, around 164 are currently in our intensive care units. And again, that includes patients that have been positively identified as COVID or we're awaiting those test results. Now, of those 164, about 139 are occupying ventilators or using ventilators. And again, that's a combination of COVID positive plus our suspected patients that we're waiting for lab results. These numbers track pretty closely to what we're seeing as a nation, which is about 30% of patients that are admitted to the hospital are going to need some sort of intensive care. And of those in intensive care, around 70% are going to need ventilators. And so this is playing true in St. Louis just as it has throughout the nation. So I'm going to now move on to this slide that I produced yesterday, and it's called The Hammer and the Dance. And so as I discussed yesterday, there are certain things that we need to be doing in these different time frames. Many of these things have already been implemented thanks to the forward-looking of our elected officials, and that included increasing social distancing, shutting down large venues, all of the public messaging, and then starting to do testing and tracing. So that will keep us on the purple curve, and that is what we need to be focused on, is staying on the purple curve. Now, what we're worried about, though, is that long distance measure as well. So if you look at the modeling and look at data coming in day by day, you don't want to fixate too much on those fluctuations day to day. You look for trends. And so that's what we're going to be concentrating on as this data keeps coming in. But just because the data turns one way or the other does not mean that we need to decrease our social distancing or to stop doing the things that we are doing now. And again, it's all of those things that can decrease the spread. Hand washing, cleaning surfaces, staying 6 feet apart. All of those things are going to help decrease the spread. We know that if we can keep those cases from accumulating, that we can manage this as a healthcare system. As I mentioned, all of those patients that are in the intensive care unit and on the ventilators, they take an immense amount of resources, both from equipment, from personal protective equipment, from ventilators, but also it's a huge strain on our staff. And we have to make sure that they're able to handle the surge of patients that we know are coming. And really the only way to prevent that is to prevent spread. If we prevent spread, then we prevent infections. If we prevent infections, then we prevent patients from coming into our healthcare facilities. If we can limit that number, we know that our ICUs won't become overwhelmed and we won't have to be faced with that decision on whether we have enough ventilators or not. So extremely important that we keep following the advice, keep the hammer down on coronavirus. So I'll just conclude here with saying, it's up to everybody in the region. If it seems like I circle back to that, there's a reason for that. The best strategy for this is to decrease the number of patients that are infected. We're buying time right now so that we can catch up with protective equipment, with ventilators, and hopefully catch up with vaccine, although that is still a ways away. But really, we're buying time and we're trying to make sure that we can handle all of the patients that come within our facilities. And with that, I think that's the conclusion of my remarks and the data that I wanted to show, and be happy to answer any questions that anybody would have. I don't have those readily at hand. I'm sorry. The question was, what do the statistics look like for people that have recovered in the community? And so that's a great question, and it plays into how you look at models as well. So the population that is recovered, and the reason for that is those patients should have immunity to the virus, right? So we don't have exact numbers for that, and let me explain why. So we certainly have numbers of patients that have been discharged from the hospital. But what we don't know is we know that there's a population of patients out in the community that probably have had COVID that were never tested, right? And it's probably actually a pretty sizable number. And so we use estimates based on the number of patients that we've seen in the hospital to derive that community number as well. And so it's a tough number to come up with, but we can certainly look at number of patients that have been discharged from the hospital, and that'll give us a broad aspect.
So that's not the number you have right now?
No, sorry.
Speaking of that idea of people that have recovered that might have these antibodies, is that something that we should be looking at as a community, is testing potentially recovered patients to have that knowledge? And is that something that the hospital systems are looking at?
So the question was, should we be testing patients that have recovered, or really, I think what you're talking about is population or more, how many people in the community have already had the virus and are now immune? And that's certainly being discussed, not presently in St. Louis, but across the globe. It has been. So there's places in Europe and the Far East where you can do antibody testing to see who is immune and who isn't. And there's discussions of having sort of this immunity passport so that you can get back out into society and start opening up, economic and other social things. So it's not as well developed right now, but that's certainly on the list of what people are talking about. So the question was, do we have good estimates on personal protective equipment and whether we've started to receive those from the Strategic National Stockpile? So we're still collating the data for personal protective equipment, and it depends on which piece of personal protective equipment you're talking about. So whether it's a surgical mask, N95s, isolation gowns, all of those things. And those vary, and they really vary from day to day. I can tell you that our supply chain officers are coming together to look at that data, but it can be anywhere from a day's worth, or I'm sorry, a week's worth of supplies on hand, all the way up to several weeks, just depending upon the specific item that you're talking about. As far as the Strategic National Stockpile, we have been working with the county, the city, who are really the conduit to the Strategic National Stockpile. I personally don't know of any deliveries that we've received from the SNS, but that doesn't mean that we haven't had any.
Following up on that question, we continue to hear from nurses, from healthcare professionals concerned about the lack of PPE at their hospitals, including SSM, saying that they are being required to wear these for X number of shifts, X number of hours. Can you talk to the public about that and
Sure.
kind of why that's happening, and is it safe for us as healthcare professionals?
Right. So the question is, and correct me if I'm wrong, continue to hear from healthcare providers about shortages of personal protective equipment and having to do what's called extended use on personal protective equipment. So what healthcare systems do, and again, we've all coordinated on this, the major healthcare systems within the metropolitan area, is how do we conserve as much personal protective equipment as we can. And so, healthcare workers are no different than anybody else. When faced with some uncertainty, it can create a lot of anxiety, and it's rightfully felt that way. So what the healthcare systems do, though, is we follow the CDC guidelines on what crisis standards of care are for personal protective equipment. So if you think about, you have a limited asset that you have, and as I mentioned yesterday, the supply chains are extremely challenging. I think I said, we're scouring the globe, and we are, to find personal protective equipment. And if you've listened in the media, we compete against other healthcare systems. We compete against other states. We compete against other cities for this limited supply of personal protective equipment. So the strategy that we put in place is, how do we look at risk for our employees? So certainly patients that have COVID that are being taken care of by our employees are at high risk, and we ensure that they have all of the proper personal protective equipment. Employees that we consider at low risk, so not working around COVID patients, doing something that is not patient-oriented, are at low risk, and so there's a different level of personal protective equipment for them. Now, in regards to extended use, that is a strategy that the CDC advises that we use when we have limited supply of personal protective equipment. These are all based on best evidence. There are published guidelines on how to do extended use of personal protective equipment, and that's what we follow. So again, I don't want to make it sound like we aren't appreciative of those concerns, because we certainly are. And if we had, unlimited supply, it would be a different story. But frankly, we don't have unlimited supply, and we can't focus purely on the here and now. We have to focus on the entire pandemic. I want to make sure that we protect our employees both today, but also over the long haul. And so what we don't want to do is run through all of our personal protective equipment in the short run, only to not have enough in the long run. Great, thank you. So, question: when do area hospitals expect to hit the peak of COVID cases? So, the modeling shows us, as I mentioned yesterday, in the next 2 to 3 weeks, we expect to hit the peak. It's always a little bit dangerous to give an exact day for this is when the peak day is, because the pandemic changes day to day. Spread is going to change from day to day and week to week. And so, but the way that the model was run, the way that we're looking at the data coming out of it is it will peak within the next 2 to 3 weeks. Now, again, that could all change, and a lot of that is dependent upon what happens out in the community to decrease the spread. What is your response to Governor Parsons' stay-at-home order? So I was pleased to see Governor Parsons' stay-at-home order, and really anything that we can do to decrease spread in the community is the right thing to do. We know as a metropolitan area that people travel in and out of our area that don't necessarily just live in the immediate vicinity. People come here from surrounding areas for various reasons and also to get health care. And so anything that we can do to decrease spread is a good thing. Do you have predictions for how many cases, deaths in the region by the time this peaks in 2 to 3 weeks? So I'll give you a range on what the models have shown us. And so it goes anywhere from around 1,300 cases hospitalized at the peak up to around 3,300 plus. And that is sort of a worst case scenario. Now, certainly we don't want to be in that worst case scenario. We want to be on the lower end of that. I showed you the numbers for where we are today. It's around 460 patients that are hospitalized. So if you look at that 1,300, it's roughly about 3 times what we're currently at. We are handling all of the current patients fine. We have enough ventilators. ICU is not at capacity. But we know if we're pushed to that level, it's going to put a strain on our resources. And certainly if it's pushed to that 3,000 patient level, it could potentially overwhelm our ICUs and our ventilators. And so, but the key to that, and again, I don't want people to focus so much on how many ventilators do we have and how much ICU capacity we have, because what happens there starts now. If we can prevent spread right now, we don't have to get to that 3,000 number. So whether we get to there or not is entirely dependent on the community. The healthcare services are reacting to what the spread is in the community. So this has to be a combined effort, not just of the healthcare systems, but elected officials, community providers, all of the above, in order to prevent the spread. How many hospital beds are currently available and how many ventilators? So I'll have to go back and get those specific numbers, and one of the reasons for that is, as I mentioned yesterday, hospital beds aren't just purely devoted to COVID patients. We still have other people suffering from heart attacks and strokes and all sorts of other things, including trauma, that occupy space in our hospitals, and we have to make sure we have an accounting for them. Those numbers, as you can imagine, fluctuate day to day. And so getting a precise number is always a little bit challenging, and that's in addition to ventilators and ICUs. We are on, so we're collating data right now on all of those different statistics. The ventilators can be a little bit tricky, and that's because we're looking at different ways that we can increase our ventilator capacity. There's some strategies to convert anesthesia machines to ventilators as well as BiPAP machines. And so what we want to know is what is the total number of machines that we have that can provide ventilator capability. And then, even more importantly is, do we have the staff that can man them as well? And so it's a little bit of a game that we play. Even though we can create space and get stuff, we still have to have staff, right? And so we're playing with all of these different legs on the stool to make sure that we can take care of the most amount of patients as we can. Last question that I have written down here: what is the status of testing, and can hospitals expand who gets tested? So I'll talk a little bit about testing. Testing is still not widely available, and I don't think that's news to anybody here or anybody listening at home. We do continue to have, and as I mentioned yesterday, a limited amount of testing capability. And so when you think about testing, there's 2 strategies. So one is for, does this make a clinical difference? And the other is, can I provide epidemiological evidence for the spread in the community. With limited amounts of testing, we have prioritized those to patients where it's going to make a clinical difference, as well as to healthcare workers, so that we know if they can go back to work sooner. And so that is primarily what we're using our testing for. There's another set of testing that occurs out in the community. Those are with the private labs. And so those take a little bit longer to turn around, but those are available for some of our community resources as well. I think that sort of blends into your question then about when do we start testing for immunity in the population. And that might be a better strategy going into the future if we can get those tests developed quickly and get them deployed quickly. Because really the limited amount of testing that we have right now, we have to make decisions on where is the best use for those tests. And right now, it's for what I mentioned: patients that are in the hospitals, in the ICUs, healthcare workers, EMTs and paramedics, firefighters, all of those sorts of people, so that we can maintain our workforce as well as take care of our patients. So cloth masks, it's a good question. So the question was, should people be wearing cloth masks? So the CDC came out with guidance, I believe 2 days ago or yesterday, about wearing cloth masks. And if you looked at the language, it said when all other social distancing measures aren't in place. So, in large gatherings, you can't stand 6 feet apart from people, can't do all those traditional things. So there's certainly nothing wrong with wearing a cloth mask. What I would advise, though, is if you do want to wear a mask out in public, make sure you're using the cloth mask and not a surgical mask or an N95. And the reason why I say that is those supplies are desperately needed by the healthcare industry. And so I would leave those for healthcare workers. But certainly there's nothing wrong with wearing a cloth mask out in public. I also, though, don't want that to take away from or distract from other much more proven methods for decreasing spread, which are things like washing your hands, keeping surfaces clean, all of those other things that we know decrease spread. Where I would say it's a little bit more, I think, useful is in those places where there's a lot of high traffic coming through and out. And so think of places like grocery stores, pharmacies, stuff like that are going to see high traffic. No matter how the pandemic spreads, people are always going to need to go to those places. And so if you just think about the probability, those are the places that you would want to take a little extra measure.
On that same line, we're seeing so many different stores, different Trader Joe's put out their own sort of new policies on whether it's have employees wear masks or whether it's the number of people inside stores. Do you think we need a more standardized guideline coming from either something like a task force, the state level, or local governments to ensure that there's sort of a across-the-board standard?
So I believe, if I remember correctly, and this is trying to get a little bit more. I'm sorry. Yes, thank you. So the question was, and local grocery stores have sort of set up their own policies about number of people that can be in the store and distancing and things like that. And would it be helpful to have a more generalized policy that everybody can use? And so I'm a big proponent of standards. So short answer is yes. The longer answer is, and I believe this was in Governor Parsons' announcement the other day about, I think it was 25% of normal capacity being allowed in the stores, which is fine. But in answer to your question, yeah, I do think it would be helpful, and if that's something that we could work on, I certainly could. I think it really depends, and so it depends on your surgical volume. I'm sorry, forgive me. freeing up capacity by canceling elective surgeries. So the task force came to an agreement about when we were going to stop doing elective surgeries, and I believe that was around March 23rd. And so we've been increasing our capacity for quite some time now. It seems like a long time anyway to me. So it can increase it anywhere from, and it depends on volume, it depends on space, things like that. But I believe this is me reaching back into my memory about looking at the numbers, but I believe it was anywhere from a third all the way up to maybe 40% increase in capacity. It really, though, it's very hospital specific, and so, but in general, anywhere from around 20 to 40%. You're welcome.
Thank you very much.
Okay, thank you.